Hello and good day. I am Christine and I will be presenting my clinical case study CT15 entitled CT abdomen. So first I would like to restate briefly the patient information. The patient is a 56-year-old Caucasian male, has history of colon cancer, has undergone post-resection of chemoradiotherapy, and presented to the emergency department with unexplained weight loss and 6 months of dull pain at right hypochondrial region. There is no change in bowel habit, and the abdominal pain turned sharp on the day of admission. Patient is not jaundiced and there is no abdominal mass. For the laboratory investigations, it was found that the patient has macrocytic normochromic anemia, and the serum creatinine, alanine aminotransferase, aspartate aminotransferase, and bilirubin values were within reference limits. But the patient has high total protein concentration, low albumin concentration, and a markedly increased phosphate concentration. However, the lipemia, bilirubin, and hemolysis were within acceptable limits. So the patient has to undergo CT abdomen, and the patient preparation before the examination is the patient is allowed to eat or drink before examination because no contrast will be given. And we will also explain the procedure to the patient, including how long this examination takes and what the patient has to do during the examination. For the scanning, we will also ask the patient to change into hospital gown and to remove any metallic objects in the scanning area. So during the procedure, we will instruct the patient to remain still after we position them. Then we will also provide breathing instructions, such as when they have to take a deep breath and when they have to hold their breath and when they have to exhale. For the imaging procedure, the patient position is head first and supine, and the arms are extended above head. For the centering, we will center the patient at mid-sagittal plane, at above the diaphragm, at the level of Xiphi sternum. And this imaging procedure is performed without contrast. For imaging protocol, first the self-image of epi and lateral is obtained. Then we will proceed to helical scanning. Scan direction is crâniocaudal. Scan mode is helical. Scanning FOV is from diaphragm to the symphysis pubis. The size thickness is 5 mm, and the image is acquired at suspended inspiration, which means we will inform the patient to take a deep breath first and hold their breath. Then we will start scan. Then after the scanning is complete, we will ask the patient to exhale. For the window setting, it is the soft tissue window. Moving on to the clinical reasoning, there is no intravenous contrast administered because there could be a possible kidney damage in the patient. This is because the patient shows hyperphosphatemia. In an article by Yi et al. 2013, it was stated that rapid elevation of phosphate levels may instigate sudden cardiac arrest and acute renal failure. So in order to prevent this further kidney failure or kidney damage in the patient, we do not administer the IV contrast. And there is also no oral or rectal contrast because there is no suspicion of bowel pathology. Because the patient does not show any change in bowel habit, and there is also no abdominal mass. Next, one of the reasons to perform CT abdomen on this patient is because we want to rule out possible hematologic malignancies such as multiple myeloma. And this is because the patient has symptoms that can be related to multiple myeloma, which is unexplained weight loss, anemia, and high level of protein in the blood. I have found a similar case in an article in by Lee et al. 2017. There is a study of familial clustering of multiple myeloma, which shows that colorectal cancer was strongly associated with multiple myeloma and indicated that multiple myeloma may be a part of a syndrome, including colorectal cancer. They have also concluded that when colorectal cancer is associated with refractory anemia, the coexistence of a hematologic malignancy should be considered, and bone marrow aspiration and biopsy are indicated. There's another case report by Kraborty et al. This case report, multiple myeloma is associated with elevated total protein concentration, low albumin to globulin ratio, and hyperphosphatemia, which is similar to the uh, lab tests undergone by this patient. So why we perform CT? Because CT is a sensitive imaging modality in detecting the osteolytic effects of multiple myeloma and has a higher sensitivity than plain radiography at detecting small lytic lesions. The use of iodinated contrast agent is contraindicated in patients with multiple myeloma due to the risk of CAS nephropathy and renal impairment. Therefore, it is not required for examination. And that is also one of the reasons why we do not administer contrast for this patient. And furthermore, other than osseous manifestation, CT also allows for detection of extra-osseous manifestations of multiple myeloma, and the acquired 3D datasets can be used for radiation therapy if needed. Another reason why we perform CT for this patient is also to rule out possible complications of previous colon resection, which may be the cause of the abdominal pain experienced by this patient. And it was stated in Weinstein et al. That technological advancements in MD-CT have now allowed accurate assessment of the expected anatomic changes in the post-operative colon, as well as evaluation of post-operative complications. So these are the example of CT images in coronal and axial views showing osteolytic lesion in the left iliac bone representing an osseous myeloma manifestation. We can see from this, it is shown by this arrow here and here. This is the coronal view and this is the axial view. And these images are from Derling and Banas article. So these are my references, and that is all from me. Thank you.